Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us once again Mr. Harry Gross, a young man, I've mentioned before, of great promise. Well, having said that, Harry is our head of research at our institute and keeps up a little bit with healthcare issues. And I know right now one of the things that impact people a lot are healthcare expenses. There are tremendous healthcare expenses, and people are very disturbed by that. And the government is trying to do something, good and bad, about healthcare expenses. And one reason being, it's a major voter determinant, and that's apparently what impacts politicians. The will of the voter, or what's going to happen at the ballot box. And also, one of the things that impacts that is the perception that different cohorts of the population have about issues. And these can often be suborned by political campaigns or a particular view on television or whatever. I mean, what channel you watch, you can see whatever the story is on this. But that certainly hits home to people when they have enormous bills. And I might just go for a brief paragraph or two on how we came to this situation. So shall we go back 2 centuries or so? There wasn't much that humans could do for each other as their bodies decayed, or just the travail of life injured people and took them out. And it's very hardwired in people. I'd say this is what the great Jehovah has done for us, for humans, is that we want to live. We want to keep living, and we don't want to suffer. So we don't want any pain. We like to be able to eat hamburgers, feel healthy, and generally for our creatures' time on the earth here, there wasn't much that could be done. And if it were done, it generally was not excessively expensive, and most people really wouldn't go that direction. Well, over the past centuries, I won't go into every part of it, but gradually humans have figured out a lot of the things that can prolong life and also increase health. I mean, they're real. It used to be if you were some time ago, if you were sick, the best thing to do was to avoid the hospital. You could look at, or physicians in general, I mean, not totally, but generally. So, for instance, George Washington being bled to death, the different kinds of ideas, sort of the Aristotelian ideas about fluid balance in your body, whatever different types of acidic and basic qualities that existed in your corpus. So this was there, and then things started to happen. So particularly in the 1870s, so the ideas about germs and what can be done to prevent that, ideas about epidemics, how to handle gunshot wounds, what sterility, all kinds of things that happen. And so when these things occurred, they still were not a ubiquitous expense. And so people, if they could afford it, they could pay some money for this. It was very sort of chaotically put together. The healthcare system was put together. I won't go into every detail about this, but after World War II and the European countries, they had some tradition, particularly in Germany, of the state having responsibility for this. And pretty much their healthcare systems became sort of a centralized socialist model, you could say, with the state assuming responsibility for healthcare in a particular country, not often totally, not all the way down the line, but pretty much. In the U.S., that didn't happen that way, and I won't go into all the complexities, but the idea appeared that insurance, when your employer would take care of it, that would be what was up, and the government would basically play a big role in that, and that's kind of what's happened. So the government pays maybe 80% of the health care, some of the cost of that. So the government, the U.S. government is here, and all the accoutrements of the government. And they produce a lot of money. A lot of this is recirculated income transference from taxpayers, whatever. There's a lot of money being generated. And then it goes into this system that you could say was partially socialized, possibly. And all kinds of things happen after this enormous amount of money goes there. A huge amount of events are occurring. And the knowledge of what is good or bad about this investment, it's trillions of dollars. Trillions of dollars are going in from the government, and then also to some degree from insurance companies and employers, and sometimes out of one's own pocket. Sometimes that happens. So there's this a diffuse mechanism that's placed that puts trillions of dollars into this healthcare system, and the expense has rocketed up for healthcare expenses. They're going up and up and up and up. And the question would be, is there a benefit happening from these increase in healthcare expenses? That would be something to brood about. And in general, some good comes from it. Where the money might more effectively be used in prevention, et cetera, there's not so much there. So the idea is the voter, if you want to say that, or the American citizen, can say, I don't want my feet to hurt, if that's the problem. And I'm not going to do anything about it when I'm 12 years old, I'm 18 years old. But once the symptoms occur, I'll try and do something about it. And the government is going to fund whatever happens to get it fixed. And the middleman in this, or the insurance companies, healthcare insurance companies, and this is a really abbreviated statement, but the insurance companies are there, and they're generally profit-making institutions. They're making money, and the money preponderantly comes from the government. So the government, it comes from other places, but the government is really putting a huge amount of money in Medicare, Medicaid, the VA, different kinds of ways they do things. They're also putting in place requirements about if you're doing something, what do you have to do to make the system, I don't know, let's say you're working on feet, you're a foot doctor, and this is what the government is going to require you to do before you can do anything for the feet. So the expenses are being put in place by government based organizations. The government gives them an imperium, say, this is your job, you're going to go approve the foot doctor's place. And if you come and you think something else needs to happen, you can just mandate that, and for the foot doctor to keep working, he'll have to entail these additional expenses, which you didn't think about it when you did that. So a lot of what's going on with this whole system is the government is sort of the Wizard of Oz here, directing the arrangements. And there's complexities about the requirements that are being put in place in the healthcare system, presumably to help American citizens. I mean, I think that's fair. But in general, the requirements that are put there are increasing expenses because the foot doctor is going to have to, and maybe this is all appropriate. So, well, there's too much sunlight in the the office, and so I'm going to have to buy $10,000 worth of shades to decrease the sunlight that comes in, and the actual benefit will be quite marginal. And so the cost benefit of all these new things that have been put in there are not easily understood, and so these events have taken place, and the government is pretty much in partnership. For many reasons, the politicians do not directly want to get involved in healthcare, I think, although the bureaucrats could undertake it, because the different problems that take place, the demand for money, et cetera, would fall on their shoulders, and they could not resist it, I think. If a politician were, if they were controlling healthcare in general, and someone would say, well, I demand that you, I don't know, put air conditioning in the waiting room, something like that. It never happened. Your political opponent would seize on that and enrage the public about that. So their idea is staying at a distance. So the enforcers of the whole arrangement have been insurance companies. Not that I want to criticize insurance companies, but I'll make this comment about Medicare Advantage. And so this is one event that took place recently, and the government is going to try and stop the money going into, or not increase the money that's going into the Medicare Advantage story. So basically what transpires here is the insurance companies some time ago claimed that they could do Medicare better than the government could. And so the government said, yeah, and we'll save you money. Not only, since we're a private enterprise here, we'll be your point person here. We'll be the people that are in the middle of this. And if somebody is enraged about the healthcare system, sadly, they might shoot an executive, but maybe not a congressman, whatever, if they get too upset about their healthcare. But that's kind of what's happened. So they're in the middle of trying to do two things in a mercantile way: get money from the government, and then also decrease expenses, increase their profits. So they'd like to say, it used to cost you $100 to do this. We can do it for $90, and we'll take $10 of profit. That would be the idea, and that was the idea for Medicare Advantage. That's a little short staff about it. And so the government said, okay, you can do this. You can set these plans up, and then if you are on watch television or see the advertisements, they're very subtle, and they have different people that do this. Sometimes football stars do it. And they say, call us up, and we'll do your Medicare. We'll be the Medicare agent, and we call this plan the Advantage. And so what will happen is the government is pretty much going to pay us the money that formerly would go just for straight Medicare payments will come to us, and then we'll give you a much better product. And that's the idea of what was supposed to. That's what was supposed to happen. We'll do this, but what has happened is with these Medicare Advantage plans, at least two things happen. One is that and this is the important point, this is another area of complexity that we don't have time to get into, and that is the way that charges are calculated. And the more comorbidities you have, the more the government will give you a check for these comorbidities. So, for instance, if you have you've lost hearing in your left ear, then that's a number that goes into the actual amount the government will pay out for this. So what's happened is these insurance companies went through a huge campaign to increase the comorbidity scores for all the patients they enrolled. So formerly, someone might say, well, I've had a heart attack and I can't see out of my left eye, and that's pretty much it. And so the government would then say, well, this particular patient is going to, if you look after him, you'll get $1,000 for these comorbidities. What the insurance companies have done is they've sent their minions out to interview people sitting there in their home. And, well, I've noticed that you can't hear out of your left ear. Yeah, that's right. Can you hear out of your right ear? Well, not too well. So we'll put that down at 50%. And I noticed that you're sitting down in a chair. How hard is it to get up out of the chair? Well, yeah, I have a tough time standing up. Okay, so you've got some muscle problems here. We're going to put that in. And I notice you're losing hair. Is that correct? We had a note that we'll put that down. So all of these things are accumulated. They're put in the patient's record, and then the bill is sent to the government. So formerly the government might pay, whatever number it is, $1,000 for this particular patient. We'll give the insurance company $1,000. But now they would give the insurance company $1,200. But the insurance company didn't really do anything about the hair loss or the hearing in the other ear. So they're collecting money just on the comorbidities they obtained, and then they sent it to the government. Now, the other thing that's a big deal. The other thing that happens is that this is renewed on a yearly basis. So if the insurance company understands that, well, we're keeping you as a patient, we're getting this amount, we're getting $1,000. But now we can see this next year you've had a massive heart attack and you're going to require a heart transplant or whatever you're going to require. And the government is only going to pay us $1,200, and we know it's going to cost $2,000. So we're dropping you from our rolls. So every year we go through and purge whoever we don't want there. Additionally, the other thing that happens is they look into different population breakdowns. Is if you're in a zip code number 427 and 421, and the insurance companies understand the patients that are in these different zip code numbers, then they will basically purge people that they think are in an unhealthy area for many reasons, socioeconomic things, and they've made a lot of money out of it. Well, one of the things that's just happened, which has caused a major expense change, the government is not going to increase the money they send for the Medicare Advantage. They're keeping it basically zero, and they've been routinely doing it at 5%. So every year the government said, well, they've stopped doing that. So, and their argument is, if you're not going to treat this, we're not going to treat if you're doing these things and you have no effort to treat the hear loss in the other ear, but we're paying you for it, and that's just the system is not working, then they've changed that. So, I mean, I consider that to be a good thing. That's my opinion about it, and there's going to be a ferocious discussion on that subject. Now, I'm pretty long-winded about that. I'll finally say this about this before we get too far, is the way the system has evolved, and I think we've written a paper on the subject, is a normal person could not pay for, let's say, treating a brain tumor. The amount of money that's required to treat a brain tumor, if the government is not going to pay for it, or you don't have an insurance company that would pay for it, you can't afford it. I mean, you just can't do it. It's too much money. And that's the way the system is. So we're in this conundrum about money, and every year the expense going up. And the final piece of the conundrum is that so much money is being produced that comes from the government. And the government is getting more, and it's getting harder and harder for the government to pay for it. It's getting very difficult to pay for that. And so I think we're going to reach a fork in the road where we're going to have to rejig the system. So for money purposes, I mean, there's just, if it costs $100,000 to get a brain tumor dealt with, or whatever it costs, the radiation, whatever, everything, stay in the hospital, then the system is not going to work, and we have to readjust that, and voter and patient expectations might need to change, and I'll just let it go with that. Many people are not happy with the system in other countries, Canada being one of them. People come here, there are all kinds of things back and forth. People in the UK can opt out of the system, and certainly I've had people that are just, please see if you can get me in the American system. The quality of care being higher. I think that's a fair thing to say for different problems. You could say brain tumors are one of them, but I mean, they generally different diseases here where money is more freely available wind up with better treatment. Now, how much that actually matters, but they do get better treatment. Well, all right, Harry, what kind of comments do you have on this?
Well, you won't criticize insurance companies, but I sure will. Private health insurance. Private health insurance in itself is a scam. I mean, it really is. The government only pays for about 60% of all healthcare expenses in the country. The rest come from private individuals, either out of pocket or through insurance. And because they are all profit-making ventures, there is no incentive for care. Because if you are maximizing profit, as a good firm should,
right,
you want to make sure you are taking in as much money as possible and spending the least amount of money possible.
Yeah.
That means you want to exclude the sickest people from your population because they're going to cost more to treat. It means that you want to delay treatment as much as possible so you can keep raking in premiums and not spending as much in. And it means that you want to deny care as much as you possibly can. So it is the absolute worst system design for actual good care. It made sense a long time ago.
Yes.
But we have figured out how to do care cheaper and better. And while Europe's centralized systems have a lot of problems, the NHS has a number of issues, and we do need to take into account Thatcher's gutting of the system in the 80s. But Germany works well, and they have a free market system where their insurance companies are required to be nonprofit, though. And so competition among insurance companies is based on what they will cover rather than how much they charge or how expensive it is. When it comes to things like Medicare Advantage, it is one of the greatest tricks that has ever been pulled on the American people. Health insurance executives convinced, I will generously say, well-meaning politicians in Washington. I'm going to be generous there.
Generous, I like that.
That they could provide care cheaper, they could do it more efficiently. The problem is that they run into that same problem, and they went from not just delaying care and denying care to what we call rent-seeking behavior. They're not adding anything. The government's writing the check anyway.
Yes.
They're just becoming a middleman.
They are.
And
yes.
they're siphoning money out of the system. And they're incentivized because a patient that they would normally reject in a private pool because they have so many comorbidities, in order to accept them, the government has to make concessions. They'll say, okay, we'll pay X amount for a comorbidity, right? Hearing loss is worth X amount of dollars, a maimed leg is worth X amount of dollars, etc. And so there's an incentive in the system that's a well-meaning concession by the government to get private insurance companies to treat patients otherwise wouldn't. But it means there's an incentive to be a ne'er-do-well, that there's an incentive to document every possible comorbidity, even if it's not medically relevant,
yes,
to extract as much money out. And it means that they are routinely defrauding the federal government because if you have a contract to provide services in exchange for money and then you do not provide those services, that's a breach of contract. That could be considered fraud. And these companies overcharge and potentially defraud the federal government of billions of dollars each year. I think in 2021, Medicare Advantage overbilling alone cost the federal government $27 billion. That is enough to fund NASA, to fund the FBI, it could have funded all of USAID in that stretch. And there is a real need for accountability when it comes to Medicare Advantage. I'm glad that there's finally some accountability coming because that is a long time coming. And if DOGE, for example, the Department of Governmental Efficiency, had really wanted to be taken seriously, instead of defunding USAID and killing potentially 14 million people over the next decade, if they had cracked down on Medicare Advantage fraud, they would have saved us so much money.
And
improved patient care.
Fraud's a pretty loaded word, but okay.
Well, that's a loaded word. But the amount of companies, United Healthcare just settled a fraud case with the federal government last week for I think $270 million. Right. Paid back again. I mean, so when I say fraud, I'm not using a loaded term. I'm using a legal term that is being used by the United States government against these actors.
So one of the things on that point is actually I've spoken out against Medicare Advantage in the past, but it's good and it is a big number. That's correct. And so what's happening now? This is a huge, big number that in a fell stroke something has happened. And it's obviously because these are the gatekeepers, if you want to say, the profitable gatekeepers, if you want to say that, and their idea is not to let anybody into the church, if you want to say, if we consider healthcare system, kind of a national church in a way.
Mhm.
So you can't get in there. And one of the things that maybe I've spoken about before are the way that standards of care are propagated. So one of the problems in the whole healthcare system is when people look at standards of care. Let's say physicians do that, and there's ways that people say this is the way you should treat whatever you want to treat. I don't know, a sore foot. This is the way to treat that, and this is we got to do this. You get an X-rays. I don't massage the foot for 3 days. I don't know, elevate it, do whatever. I don't know, inject some steroid, whatever, and this is what you need to do, and you better do it. These standards of care are out and open, so everybody can see that. And the problem is they rarely, if ever, make any relationship to what they call the standard of care and what it costs. So these standards of care, that's a tremendous problem. If you wanted to say what can be done to fix the American healthcare system, one of the things to do would be to examine the way that standards of care are propagated. And then actually after they're there, it's almost impossible to change them. I mean, there'd be a whole nother argument as to how this works. And maybe there's a better way to do it. But the big thing is money is left out of it. So when these standards of care are there, they're big. It's big numbers that appear. And they never paid any attention to it. They looked into, generally, in patient outcome. Well, now the patient can walk 3 miles now or whatever. So that's the reason we did this. We want the patient to walk for 3 miles. And that's our outcome, but we did pay no attention to money. So when the insurance company intrudes itself into this dialogue, what the insurance companies do, and many patient voters have seen this, they will insist on different treatments before the foot gets amputated or whatever they do, or injected or something. All these different treatments have to happen. These different expenses have to be met, and this is now our standard of care. The insurance's standard of care. When the docs or their institutions do this, the care is out in public. So this is the reason we did this. Here are 4 papers that support this or 2 against it, whatever. These are the way we did it. And for the insurance companies, it's done with money in there, and it's done secretly. So when you say, well, they insisted that I don't know, I wait 6 weeks before I get my foot massaged or whatever they say. Well, where did that come from? We have no idea where it came from. There's no idea. And so it's all done secretly, and the insurance companies are basically denying care pretty much for this. Now, what they say is, well, all right, doctor, if you want to go past this denial, you can call us up and complain. Here's the number. But in practicality, it's just for many reasons.
Yeah.
Well, I've got to call. I was on hold for 45 minutes. I've got an office full of patients. I've been called the emergency room, whatever, and the bureaucratic hurdles that are put there really serve the point of preventing access to care, which is an important thing to say. Well, I've got insurance. How often have you heard somebody say that? I feel happy. I have insurance. Well, do you really have insurance? Do you really have coverage? And that's, I think, particularly true in my experience. And looking at in Medicaid in Georgia, how hard it is for a Medicaid patient to finally receive care, and of course, the Medicaid is the last, I guess, people of economic distress are there. And the states pays a lot of it. And they put this system in place that really, really, really makes it hard for these patients to obtain care. And so when people say, and they've said to me, well, my insurance won't pay for it. What that really means is you have not used the word insurance correctly. You don't really have what people would consider insurance. There ought to be, I've got a type 3 insurance policy or whatever. It's not really a full insurance coverage for most people.
Yeah. It's the underinsurance problem,
Right,
is what we
right,
call it. Where I mean, if you factored in uninsured and underinsured Americans, you probably have at least probably a third of the country without adequate health insurance coverage.
Yeah.
At least a third,
Yes.
I would guess. And you also have this problem where you have the trade-off of you pay really high premiums every month and you get good coverage, and
Right.
you are likely to be able to get health care.
Right.
Or you pay low premiums, have very high deductibles, and you are highly likely to be up the creek without a paddle
Right.
when something really bad happens. And it's intentional. It's designed intentionally that
Well,
way.
we're getting near the end of our conversation, but yes. And so there's the sort of moral arrangements in the country are what they are. And I think we have to remember this. Everyone is doomed to pain, suffering, and death.
Mm-hmm.
We're doomed to pain, suffering, and death. And I like to think of healthcare as a sort of a church going in there. The hospitals are cathedrals. The white coats are priests. And its access to that is good. But there's only so much that can really happen in the whole healthcare system. There's almost so much that can happen, and we do all we can to prevent any distress, but that's a big problem. Well, all right, Harry, you have the last word on this.
I mean, I would say that how we fix the system is a very complicated, complex problem. There's no easy answers. What I do know is this. Our current system is not giving us the care that we need. It's certainly not providing us the care that we deserve. And there are better possibilities. We can debate what those possibilities are. We can have different visions, but we all know we can do better.
Well, I agree with that. And just get to policymakers to say these are some we won't go crazy here. But here's some things that can be done to fix the system directly. And so one of the things the government has done, and I mean, we could say Republicans, Democrats, whatever, this Medicare Advantage change is tremendous. Mm-hmm. That's a big, big number. I mean, it's hundreds of billions, certainly a number of billions of dollars just saved right away. And that's the start of doing something. And the saved money could then be used in other aspects of healthcare rather than this. Yep, well, okay. Absolutely. Harry, it's been great speaking with you. And I wish you well, and we'll have to talk some more.
Yes, sir.
Okay, thank you. Thanks.
Thank you.